My disclosures are all, Jean actually just embarrassed the dickens out of me. But my husband keeps hoping that one of these things will earn me some money, but so far, not so good. Next slide. So, um, those of you who know me know that I've been in Washington for 40 years. My husband and I were in different cities for 9 years. So the deal was once we had a job in the same place, that we'd stay there. Um, and as a result, it's been really quite an exciting time. I'm a grandmother many times over through my patients, not through my own children, but they're working on it. But more, I've really been excited to see the evolution of disease and our treatment for disease. And there's no question in my mind that OI is the place where it's been the most exciting. Between bisphosphonates, rotting, we've really changed what we can do for kids. Pulmonary concerns, we're at least trying to get on top of it. And the new meds give me great hope every day. Next slide. So this is my slide I use a lot in many different talks because it's an important message. I always appreciate modern maturity's view on things. One thing is absolutely true. I will never grow up to look like Sophia Loren, but I have a good chance of living to be 100, and some of these patients do too. And making sure that they are safe and independent, I think, is one of our very important responsibilities. Next slide. So, as I said, having been here a long time, back in 2010, I convinced the good Tracy to let me chair the scientific meeting, and we were going to look at what we know about adults. And Dr. Gloria graciously started us off with aging with OI. What do we know? We went through a lot of hard work, and we basically agreed we didn't know a bloody thing. Next slide. So this got us talking about, okay, this disorder is changing all the time. How do we capture that, and how do we ensure better care? We then I was just learning to use the online tools and whatnot, but NIH, God bless them, had PROMIS instruments and a free tool, and we surveyed the OI community. And to our delight, we got in 3 months over 1,000 responses to our completely poorly done survey. Too many questions, too complex, you name it, I did it wrong. But of these incredibly difficult surveys, 951 were absolutely down to the oomph. It was terrific and quite an honor. Next slide. Back then, and it's not quite the same today, so that was our paper. Next slide. What was ranked most important was musculoskeletal. Pulmonary, interestingly enough, and we didn't really see it when they talked to us about it, was pulmonary. It was third place. We weren't really hearing it. And one of our big, big mistakes was we totally missed the concept of pain. We did it a little bit, but not very much. And it was an important, I would argue, miss. Next slide. We saw that our patients were different than that's the US population. We divided our responses into mild, moderate, and severe. And down at the bottom, you'll see shortness of breath, sleep apnea, wheezing, were right up there. The cardiac was increased, but not all that bad. Next slide. With the help of the PROMIS instruments, we did identify, and I've circled in red, if you haven't used PROMIS before, they're basically three vertical lines. One is sort of the standard, and then you have basically a range of 5 points in their Z-scores, and you expect most everybody to fall either inside the vertical lines. We saw and we were concerned that general physical health was way below, but I would be honest and say we weren't really focusing on pain interference, the other red circle, being so far above the top vertical line. We did, however, next slide, feel very that we had something to say, and we presented it at the 12th scientific meeting. But again, we said we have a tremendous amount to learn. There's so much we really don't know. Next slide. Thanks to Tracy, one of the absolute demands was that we include the patient's voice. And we were really lucky, next slide, because PCORI came on the horizon. And for those of you who aren't aware of PCORI, it's Patient-Centered Outcomes Research Institute. But this was started during the Obama administration because of the deep concern of many clinicians that were doing all this great scientific research, and the patients didn't give a damn, and they didn't respond and didn't do what needed to be done. And we were thrilled to get some of their money and start surveying people within the OI community and getting them to participate in our research. Next slide. And you know, I'm old enough. You know, we used to come up with all our hypotheses and whatnot, but we did it all. And it was a one-way street. And PCORI is terrific because they have a very different perspective. It's got to be a two-way street. Patients have got to be involved. And so for all of our projects, next slide, we had the patients involved from the beginning. What were the questions we were going to ask? Not Tosi's 13 systems done with too many questions, but our PCORI work was much more patient involved. And patients were involved in what we were going to ask, how we conducted the study, how we interpreted results, and how we shared the findings. And that was really an important message that we heard. So many patients said, I participated in XYZ study, and then I never heard anything more. Next slide. Throughout everything we did, we heard over and over again, you have to pay more attention to transition and adult care, or frankly, the lack of it. And the fact that we go see docs and they don't want us there. We get discharged, we get thrown out. And for everybody who's on this call, you clearly have an interest in this. I think we all know adults with childhood onset disorders are an exploding population. I love this cartoon. Sometimes if I stand in the middle of the room, no one acknowledges me. I think that it's been very, very hard to get medicine to see what's going on. Now, it's not that work hasn't been done. Next slide. And I am most hopeful that everyone has heard about the gut transition program. Now, these guys are very energetic, and they would say, get that transition policy in there early. 14 to 15, start tracking and monitoring their transition progress. 14, 15, transition readiness. 14 to 18, transition planning. And then 18, start transferring to adult-centered care. And 18 to 26, confirm they made it. Now, I don't know about you, but that's a world I don't live in. And luckily, one of the founders of Gut Transition went to medical school with me, so I had the opportunity to torture her about this regularly. Next slide. And I kept saying, you live in a world where people understand the conditions and are willing to take them on. But our patients aren't having a soft transition like the figure on the right. They are falling off a cliff, and they are in deep, deep trouble. It took me a long time to be listened to, but that's a different story. So we then went on and said, okay, we're going to really work to find out exactly what's going on here. Next slide. And our next PCORI award was in fact preparing adults to engage in research on access as well as quality of care for their rare disease. Next slide. And really, hats off to the OI Foundation staff who were so hard. The listening sessions were huge and took a lot of time, but we spoke to a ton of patients and caregivers and people in policy, people from other rare disease organizations with our listening sessions. Next slide. We found that there were a number of different issues, but they mostly fall into 4 buckets. One, there is no planning right now for transition. Providers are a problem, and advocacy is needed to get more rare disease organizations working together, and finance is a big deal. So let me dive into that a little bit more. Next slide. So what they told us is that we need to increase our transition guidance and referrals. We do need to get our patients learning much earlier about how to manage their own care. And one of the things that was asked for is a standard template for OI clinic notes to keep better track of clinical needs. I don't know about you, but is it Cerner? Is it something else? That we couldn't really work on, but boy, did Tracy step up. And I do certainly hope, and I'll hit it again with Vigat further on, to get the OI adult handbook so that people have real language documentation to give to their adult clinicians. Next slide. Lack of providers. Now, part of this is Medicare and Medicaid reimbursement isn't very good. So we have a real problem there. Our patients, our providers are afraid of the liability. The providers out there, when they get away from peds, aren't trained in OI or other rare diseases. And over came up, I don't want to go to the ER. I don't want to have to train the doctor. I'm afraid they're going to hurt me because they won't know what to do. One of the discussions we won't have today is the debate, should we push for centers of excellence versus should we try to improve care on a more local level? That's a real toughie. And there was no question that expertise and literature is concentrated on the pediatric patient. Identified, but something we really aren't going to be able to work on. Our patients are used to a multidisciplinary clinic. Adult care is balkanized. That isn't going to change overnight. The adult community expressed with vigor that they weren't always so sure that what they were being told to do was really right anyway. And then, of course, and I will drum this in simply because we missed it so badly early on, the significant prevalence of pain and the disabling aspects of that were key. Next slide. Tracy reached out to leading voluntary health organizations, and we were appalled to find that most of the folks out there were not focused on this at all. And so I'm tickled to tell you that we've started trying to raise this issue at every possible meeting we can go to. Next slide. And the finances are really an issue. Medicaid is a problem no matter who you are and what disease you have. And many of our patients are stuck with Medicaid and Medicare. And we're very pleased to support the advocacy organizations that are looking to try to increase the reimbursement for folks with rare disease. As I mentioned, if people don't have good insurance, they can end up with exorbitant emergency room fees, so often they won't seek care. And something that came up, though, was not part of our basic effort. Problems with employment and affordable housing are very important to these folks, and ends up affecting both mental and medical health issues. Next slide. So one of the great things is the work that other people have been doing. And hats off, Tracy and OIFI got together and did a very different sets of surveys. They did the impact survey and also pain and OI survey. But if you can drill into your computer, what's interesting for me as an orthopod, when with the impact survey, note that pain was what people were really concerned about, and that fracture is below the middle. Interestingly enough, our adults are having more soft tissue injuries, dislocations, sprains, etc. And we have very little research there and a lot of work to do. Fatigue there, dental, hearing, joints. That's a toughie. But again, it set in motion the fact that we need to really spend more time on pain management, and I'm so pleased that it will be a talk coming soon. Next slide. OIFI and Tracy have now published a total of 3 papers, and I urge you to track them down. It's the impact survey. So we ended up with this huge, next slide, shopping list. And you know, you stand back and you say, well, we don't have a lot of money. How do you make a difference? So a couple of nice things happened along the way. First of all, next slide, got transition, got religion, and not that they were interested in rare disease, but they started recognizing that adults with complex issues were also falling through the crack. And with their much bigger name, much bigger clout, much bigger budget, they have really started work on complex care. And next slide. There's a huge amount of overlap. They want to be sure that the medical school curriculums are changed, that the future health workforce is different, that they have to be exposed to complex care and rare disease. Supporting the current primary care workforce is something we can do, and I'll speak to that again in a minute. But making lots available easily is our goal. Payment policy, too big an issue, but we're there supporting it all we can. Supporting research to improve care, absolutely. And building a coalition of interested organizations to support expanded adult care, absolutely. And that is something that Tracy and I have been working on to our great delight. Next slide, because people have been really interested. So again, engaging the patients from the get-go has been essential on this. And what has been our basic strategy so far? Next slide. First, arm the patient. We can't change medical school curricula, nursing curricula overnight, but we really can try to reach the patient population every day in every way. So, next slide. I urge you to be sure that your patients I hope they carry a notebook or carry their adult handbook with them, and that they know to turn to the pages that say resources for medical professionals. And Tracy, in her incredible way, has made it really easy to access TeleECHOs, town hall meetings. Not listed on here, and I'm bugging her to fix it, is the OI Foundation maintains an extensive bibliography of what's out there. Although I honestly think that it's very, very long and therefore problematic on its own, and therefore, in fact, encouraging physicians who would be interested to watch some of these OI Foundation teleechos is a smart thing for the patients to do. Next slide. Again, hats off to the OI Foundation, and they turned this adult health toolkit out with incredible vigor. The nice thing is it's kind of sturdy. It's not one of those little things you're going to lose. It's something you're going to carry around, keep in your backpack, perhaps. Next slide. If you haven't brought it up on your website before, please make sure you do. It really takes the patient through everything and talks a little bit about all the critical issues, cardiac care, dental care, emergency rooms, you name it, it's there. It talks about developing a care team and recognizing, frankly, that that's going to change all the time. All the resources that I'm going to mention to you can be accessed through this. Next slide. For the clinician who doesn't know what the heck we're talking about, doesn't matter. All the different crazy numbers that we have, it's there. Again, this is the same thing. Resources listed. Next slide. And it really provides the Berlitz of OI care, because recognizing that ER docs, primary care docs aren't going to read long essays. There's a short summary of what the issues are. And what I love about your multidisciplinary care team is I can just Xerox it and know who I need to CC my letters to. And that's one of the things to emphasize to the patient. If you're going to, in fact, be successful, you've got to keep all the members of the team in the loop. Next slide. Definitely, I suspect we need to expand it. We have the orthopedic history tracker. That's a toughie. Probably should have been about 5 pages, but we'll work on that with the next edition. Medication tracker, absolutely essential. Next slide. And again, the next time I'm going to put this in bold. Caution, I have OI. Handle me gently. But there are lots of other great things that are going on in that book. But I just want to highlight them and encourage you to encourage your patients to start using this, not when they're 25, but 16, 17. So they start really getting all that data together and start speaking up for themselves. Next slide. The foundation, if you're not aware, has created and is busily updating a provider list, not just for orthopedics and endocrinology, but for those tough to get at specialties. Dental, a biggie. GI, almost impossible. But we're actively trying to track down those folks so that we have names. Next slide. Tracy has worked very, very hard to expand the OIF. Well, she's really reinitiated the OIF support groups, and they're now all meeting quarterly. And she's divided the country into 5 different regions, and it's actively pushing them. Next slide. I hope you've all had the opportunity to be part of a regional meeting or you're helping organize one in your town. I think this was one of the great brainstorms that Tracy brought to the foundation. She recognized that, yay, we have big attendance at the national meeting, but she also recognized it was pretty much always the same people. And certainly I find in all of my patient families where someone has a challenging disability, family finances tend to go downhill. And a big meeting that's not close by is just impossible for them to get to. And the beauty of the regional meetings is they're 1 day meetings. They're on a Saturday. People aren't missing work. We have some elements of childcare, not always complete, but we do. And we can stuff a lot into a meeting. And frankly, I think for the patients, making new connections and new friends is really important, particularly for my kids who feel that they're all alone and nobody cares. Next slide. And we're so pleased that Tracy Mulroy has stepped up. She's not just doing the Jamie Kendall Fund, but the Adult Health Initiative Community Chair is her new title, as we really look to be being sure that we're responding to what the community wants. Next slide. Arming the docs. Here for you guys. So next slide. Certainly the natural history study is continuing to march on. We did get our 1,000 participants, most of which have been followed for 10 years. And Brendan Lee and all have led us unbelievably to create that data and work with it. Next slide. We've really expanded significantly. Next slide. Into patient-reported outcomes. And I would argue that this has been one of the great triumphs of improved patient involvement. Next slide. I also encourage you, if you're not aware of it, to take advantage of the OI registry. This is owned by the OI Foundation. It's managed by the University of South Florida. But we've been able to use it for the foundation to answer questions that were hard. And other folks are using it, Deb Krakow and others, to move forward on critical questions like problems with pregnancy and whatnot. Next slide. One of the things we did was survey multiple times during COVID, and you'll see how unartistic I am, but those middle circles helped us with an important message to the community. And what that shows you is patients who were hospitalized had moderate symptoms from COVID or no symptoms. And what you see is that among the vaccinated patients that responded, only one person had to be hospitalized versus the unvaccinated patients. It was a far bigger number. And it helped us with our vaccination campaign. This is the beauty of a quick and dirty registry, and I urge you, again, to take advantage of it. Next slide. Hats off to Eric Orwell. He has been very important in terms of getting us started on Delphi panels. I don't know if you've all participated in them before, but when you don't really know the answer and where the research is not very good, and when you look at cardiac, frankly, it's mostly case studies. You have to go through all those case studies and then use a expert panel to try to come to a opinion. A decision maybe, but an opinion at least of what the important next steps are. And Eric led us through a wonderful program on cardiovascular disease in adults with OI, clinical characteristics, care recommendations, and research priorities, identified using a modified Delphi technique, is in full manuscript state and out and being shopped. So hopefully we'll have it for you available very soon. Next slide. One of the things that came up during all of our early PCORI work and whatnot was that, in fact, it's about 15 or 20 OI centers that are regularly part of our scientific meeting. But in fact, over 50 pediatric centers, and depending on how you count, 6 to 8 adult centers um, uh, say that they're OI centers. And we weren't having a lot of contact with them all the time. And we wanted to be sure that everyone was up to date. And so I hope that you've participated in our town hall meetings. That's our quick and dirty updates to try to be sure that everyone is up to date on the best information we have available. And they're kind of fun. And we just did one a few weeks ago, and we'll be doing one again in the fall. Next slide. Hats off to Eric Storch. So this pain thing has become very, very important. And he has now got several papers and is perfecting an instrument on pain and anxiety, which I think will help us track what we're doing over time. And Storch, Storch, search on that name because he's doing a great job for us. That's for sure. Creating connections. Next slide. Hopefully you have all become aware of the great work that folks are doing with case discussions. So Rich Cruz is doing an international OI surgeon study group. Megan Wallace, Jean Franzone, Jill Flanagan do a US quarterly case review, and I am so grateful for that. And coming soon, Danielle Reynolds and Pam Smith are going to be doing these probably quarterly meetings again on medical management. So often it's not just the patients that feel alone, it's us. And so this, I think, is a great opportunity to know each other, share the things we're doing right and the things we're doing wrong. That's for sure. Next slide. Again, I want to really thank the adult community. The Jamie Kendall Fund has been absolutely extraordinary in terms of helping fund the work that particularly Sandy Sandhouse and Kathy Raggio have done, helping redefine, and I do use those words, redefine what we think about lung disease in OI, and recognizing that it's not scoliosis, it's the issue. It is the tissues, and making me, at least, much more responsible about making sure my patients get their pulmonary functions checked on a very regular basis. Next slide. And Tracy, as I said, if you go to the OI website, current OI studies and publications, basically everything that's out there is listed. Now, as you know, Tracy has been very active in the Rare Bone Disease Alliance. Next slide. The issue of what can we do to lift all the boats is really an important issue. Tracy has been spectacular helping the smaller rare bone disease organizations. And one of the things that we've done as we've pushed this forward, next slide, is we had last year a program originally called Nowhere to Go for adults with childhood onset rare diseases, but Tracy's always more positive than I am, and she changed it to Somewhere to Go. And I think we will do a better job if we help the other rare disease organizations. Next slide. So we did that in October, and we're working on our next event, which will hopefully be in early 2025, where we are going to start to look at what the patients feel should be the measures of success in transition, in access to adult care, in quality of adult care. We're also working on a landscape analysis to figure out what other people are doing so we don't duplicate our efforts. Next slide. And it's important that OI is really tough. One size doesn't fit all, that's for sure. Our patients are so diverse. Next slide. And so as I look at some of the things that I'm pushing Tracy to do, one of the critical things is, can we get a consensus with the clinicians, with the patients, about what a cadence of care should be. There are a vast number of people on this call, but I find, for instance, the AAP's direction on what I'm supposed to do in the first month with achondroplasia and what I'm supposed to do by the age of 1 and by the age of 2 is really helpful. And I think that we should start talking about this. Our data isn't perfect. But I think that we could really start to set some standards and try to get on their website because that is incredibly helpful across the age span. When should we screen? When should we say, okay, you need that cardiac echo? When should that first pulmonary function be done? Next slide. What works best for everybody? I don't know. The jury is still out. I love centers of excellence, but that doesn't help the people who live in remote areas. How do we help them have a local care team so that they don't have to go to a center of excellence for everything they need done, because frequently people can't afford it or their insurance won't let them go there. So I think we have a huge amount to learn and do. Next slide. What do the next 50 or more years look like? I don't know. There won't be immediate answers, but we certainly have some early tools. We're working hard to make them better. We need everybody to work on this. You know, it's just like my 401k. My husband kept making me put money into it. Thank God. And we're moving forward, but we've got great leadership, next slide, and support from the OI Foundation. And I just really want to thank the OIF staff. They've been terrific. None of this would have happened without them. And thank you for listening.